All right, our next speaker today is Dr. John Clancy. Dr. Clancy is the Gunnar Esiason Bell Professor of Pediatrics at the University of Cincinnati and Cincinnati Children's Hospital Medical Center, where he's the Research Director in the Division of Pulmonary Medicine. Dr. Clancy?
Thank you for that introduction, and I'm just going to spend some time discussing some of our background understanding regarding CF pathophysiology, how CFTR works, and some of the exciting new research based on CF genetic information, which is now becoming available for patients. I wanted to just provide this brief summary of this. I don't think any of the work that I'm talking about today will be influenced by any of these, but I do have grant support from the NIH and the CF Foundation, and I work with a variety of companies who are in developing new therapeutics for cystic fibrosis. So cystic fibrosis is an autosomal recessive disorder, as we're all aware. It occurs in approximately 1 in 3,000 births in the U.S., and there's been over 1,900 mutations identified which are associated with CF, and the common thread is a loss of function, being a recessive disorder. And it does affect multiple organs, as outlined here, including the lungs, several organs that are part of the GI tract, and the hepatobiliary system, vas deferens, and potentially others, but these are certainly areas where everyone agrees that CF pathology occurs. Median survival is approximately 40 years, but one thing for us to remember that when we look at 1 year, in a 1 year time frame, what's the average age of death of patients? It's approximately 25, 26 years. So people who are dying of CF are still dying very early, tending to die in sort of their early adulthood. And we know that the CFTR gene codes for the CFTR protein, which stands for the cystic fibrosis transmembrane conductance regulator. And CFTR, how does it relate to disease? And I've shown here just a slide that sort of takes it from the loss of the protein function to the different manifestations of the disease. When we lose CFTR function, this in turn leads to reduced chloride transport, bicarbonate transport, and also a typically enhanced sodium transport across different epithelia. And the strongest working hypothesis is this loss of this ion transport or dysregulation of this ion transport leads to dehydrated airway surface liquid and glandular secretions, and that the secretions themselves are very thick and tenacious. And if we look to the right, this is just a scanning electron micrograph of an airway from a patient who died from cystic fibrosis. And what we're looking at is basically a mucus blanket, and right in the center of the slide is mucus that is exiting one of the submucosal glands. And if we peel back what's underneath the mucus, what we find is that the cilia that normally are fully extended and helping to clear their overlying mucus blanket are indeed flattened and often non-functional because of the thick buildup of mucus on top. So our working hypothesis is when the mucus is abnormal, this leads to an environment that is very prone to infection, inflammation, and airway damage. And that's shown down below in the H&E section. We're basically looking at a cross-section of a lung sample from a patient who died with CF. And right in the center of the slide is a big plug of mucus in a bronchus, a bronchiole specifically. That pinkish area in the middle is mucus, and if we zoomed in, we would find that it's sort of mixed with bacteria and with neutrophils and a very sort of acute inflammatory response. And we know that the end stage pathologic finding in the lungs of cystic fibrosis is bronchiectasis, and unfortunately, that's the primary cause of death in patients with CF. So when we think about all these different steps where we can intervene, this is where current CF therapies are available. And when we're talking specifically about pulmonary therapies, chest clearance is certainly a tried and true method to help clear the secretions out of the lungs. But we've also got a number of additional tools that are available to attack different aspects from the sort of the upstream part of CF disease to sort of downstream approaches. And I've just brought up a slide here that shows where those different commonly used therapies now we believe they intersect with the disease, the chain of pathogenesis. 7% hypertonic saline helps to hydrate the airway secretions, and so this helps to bring more water into mucus secretions. Dornoise alpha, which is recombinant human DNase, helps to break up DNA that is found in the mucus and helps to thin it. So it's really targeting the thick mucus that's accumulating in CF. Nebulized antibiotics obviously target the microbacteria, which are other microbiology, the different bacteria that are found in CF, and thankfully there's a number of options available. And then at the bottom I have ibuprofen and azithromycin. These are felt to attack some of the inflammatory changes that or some of the inflammatory pathways that we think are relevant to CF. So we certainly have made great progress using these available therapies, but as you can see, they're relatively, some of them are very downstream in what we think is the disease chain of disease pathogenesis. The product of this is shown in the following slide, and what we're looking at here is age in years on the x-axis, while on the y-axis we're looking at lung function, which is sort of a relatively agreed upon means of monitoring wellness or status in CF patients. And we have two curves. The yellow curve up below is data, cross-sectional data from the CF patient registry from 1990. And on the the white curve is basically same data, but showing the snapshot in 2008. And the good news is there's been a great shift in that curve. Indeed, if you look at lung function over time, it has shifted far to the right, and we're seeing that older patients have better lung function. But at the same time, you can also see these are rather parallel curves. Yes, they're improved, but sort of the nature of the loss of lung function with age, at least over time, remains unchanged. And so the working hypothesis in CF is that we really need to tackle some fundamentally different approaches to really change the shape of that curve, so that the loss of lung function is actually is changed or hopefully stopped completely. And that's where some of these newest therapies are really we think have the potential to really change the face of CF. And what's exciting about them is that they really target well upstream of everything that is currently being used for CF therapy. We're basically targeting the dysfunctional CFTR proteins, trying to restore function, so therefore all the downstream manifestations will be changed or hopefully improved. And this class of drugs is called CFTR Modulators. And what I'm showing you here is a cartoon of an airway epithelial cell. It could be another CF-expressing cell, but most of the data so far has been focused on looking at lung function outcomes. And these are just three different approaches which have made their ways into later phase clinical trials, and in fact, indeed, for one of these has actually been FDA approval. And I'm going to start at the bottom and work my way up. But the ways that CFTR can be dysfunctional are numerous. Again, I mentioned 1,900 different mutations, but people have tried for years to try to help classify them into different groupings that sort of behave in a similar fashion. And this is one example of that. Class 1 mutations are biosynthetic defects. Includes it can include a number of premature termination codons, and I just showed the most common of these, G542X. And again, there's other biosynthetic defects that can cause CF, but one of them includes premature termination codons. And one approach to restore function to a premature termination codon is to use a drug which is capable of suppressing that mutation. Basically what that means is the drug leads to the ribosome reading past the premature termination codon and continuing to the end of the full-length gene so that a certain amount of fully functional full-length protein is produced. Again, these studies have made it into phase 3, and I'll go over some of those results a little bit later. Correctors, as we move up, are tackle the most common cause of CF, the delta F508 mutation, where the phenylalanine of position 508 is missing. This is considered a class 2 mutation, which really means that at its core, its problem is the protein doesn't fold correctly. And correctors really aim to improve the folding, or at least help to improve the trafficking of F508 to the cell membrane, where it can go and do its job and help transport or regulate ion transport. Class 3 mutations, these are basically situations where the CFTR is capable of getting to the cell membrane. It's available, but it's unable to open, and typically this means it's got a problem with its regulation, often with one of the nucleotide binding domains, or NBDs. G551D is the most common member of that class, found in about 4% of CF patients. And drugs which target that type of mutation, a gating mutation in CFTR, those are termed potentiators, and that's certainly some of the most exciting work that's going on in CF right now is with drugs along that nature. What I first showed you on the left side were mutations typically considered non-functional, and we often call those severe, and that really reflects their the amount of measurable function in vitro systems. On the right side are different types of classes which in general are predicted to have partial function, and in general they have a milder phenotype. Class 4 mutations are mutations where the CFTR gets to the cell membrane, but its conductance or its ability to transport chloride is reduced, and the most common mutation in that group is called R117H. Class 5 mutations, it's essentially a normal CFTR, but it has a splice, an abnormality in splicing that reduces the amount of normal CFTR at the cell membrane. So it's there, it's just not much. And finally, Class 6 mutations tend to have a very short residence time at the cell membrane, so they internalize quickly, and so they're not always available to do their job. And as you might guess, these classes are not necessarily completely exclusive. So one mutation, for example, delta F508, while its primary problem is its ability to get to the cell membrane, if you get it there, it has abnormal opening, and so it does have some class 3 characteristics, if that makes sense. So, but what we're trying to do now in the CF field is really trying to develop drugs which target these different classes of mutations, and we're now at the place where we're bringing them to patients in clinical trials. So to really understand how CFTR is regulated, there are really just a handful of things that influence the cell factors which influence the channel's ability to transport ions. And first of all, this is just a cartoon showing CFTR, the cell membrane. The big hole is basically the pore for chloride and bicarbonate and potentially other ions to transport across the cell membrane, and the little green structures down below are sort of the regulators of CFTR that help it to open and close. Those are the nucleotide binding domains. And one approach is to increase the number. Well, one of the important aspects that controls how well CFTR is doing its job is essentially just how many channels are in the cell membrane. And that's what correctors and suppressors try to do. They try to increase the amount of CFTR in the cell membrane. The second aspect to consider is how much time the channel is spending in an open versus a closed state, and that's what a potentiator is trying to do, try to alter how well the channel is able to open. Finally, there's another characteristic of channels, which is basically the size of the pore, and that's called its conductance. Currently, no drugs are really targeting that, but it's another way that you could help to increase the total amount of ion transport. So all these drugs that are sort of in development are focused either on bringing more CFTR to the cell membrane, or once it's at the cell membrane, improving its ability to open in a more normal fashion. So what I wanted to summarize were some results from recent clinical trials. Some are published, some have been presented at meetings that are showing how we're bringing these CFTR-directed therapies to CF patients. First, to summarize, we'll go through some results with potentiator monotherapy in patients with the G551D CFTR mutation, and also more recent data with other gating mutations. Combinations. Drugs are being developed in combination potentiator plus corrector to target mutations such as F508. Suppressors, again, drugs which are attempting to restore function to premature termination codons. How are we bringing modulators to rare genotypes, and how are we bringing modulators to other populations that are sort of outside the usual or the earlier stages in drug development? Young patients, healthier patients, maybe very severe patients, patients with really rare CF-causing mutations. How are we tackling that? So when I'm going to be showing you data that sort of is laid out in a similar fashion, so I just want to give this as a sort of an outline that will help us to sort of think through how these studies were designed and some of the constraints in study design that were helpful in bringing these, we think are bringing drugs to these new populations. So first we have to think about moving from left to right, for the various CFTR mutations, what type of sample size, is it small or is it large? Obviously, this is a rare disease, so none of these are particularly large, but some of these are ultra-orphan populations. Within the CF group of 30,000 patients in the U.S., we may be only targeting 1,000 patients for some of these mutations. So this becomes a major driver of the design, and the types of designs that have been used include parallel, crossover, and adaptive based on those just feasibility numbers. Mutation homogeneity, this is really, are we thinking about developing a trial around one specific mutation, such as delta F508, Or are we looking at a group of mutations which fall within a class, such as a number of gating mutations that could be potentially used, or could potentially benefit from a drug like Ivacaftor, which targets, helps potentiate CFTR. So those are one additional consideration that help us decide how we're going to establish our studies. The background function of the mutation. I've mentioned there's sort of two general, very broad groups of CFTR mutations, those that are kind of considered severe or very little, if any, function, and those that have partial function. And that influences the disease background variability, which in turn will influence sort of the size of the trial that you would need to develop. So in other words, being able to detect an improvement in CFTR function by a clinical outcome measure may be very different in a patient who has no function in CFTR compared to a patient who has partial function, because they have sort of this inherent variability across patients in how their diseases manifest. So that becomes a consideration. And finally, I just mentioned confounders. There's a number of things that can also influence these studies. Second mutations, conmeds, which could be utilized, geographic influences and care differences across different countries, which could be influences. So these are all considerations that have been necessary as we've designed trials to bring CFTR modulators to new patient populations. So the first I'm going to show you is the most recent data that has been published, looking at the drug Ivacaftor in CF patients who have the G551D mutation. These studies have progressed through phase 3, and the drug was approved for use in patients with this mutation down to age 6 years, and that was approved in February of 2012, if I'm not mistaken. And in this study, it was a small sample size. Only about 4% of patients have the G551D mutation. All of them had to have the that mutation, so there was a very homogeneous population. In general, these patients had no measurable CFTR background function, and for all these reasons, a relatively clean kind of study design, just the biggest challenge being that the numbers are relatively small. We're only talking about somewhere between 1,000 and 1,500 patients who have this mutation. And the preclinical models demonstrated very strong treatment effect, as did the phase 2 studies had robust treatment effects that included biomarkers and clinical efficacy. And this led to the trial design, which I've shown here. It was a very straightforward parallel design. There were two studies that followed the same design. The first was in patients over the age of 12 years, and the second, a little bit smaller, was in patients ages 6 to 11. And patients who had the G551D mutation were either randomized to Ivacaftor or placebo, same dose across these based on preliminary PK data. And the primary outcome measure was at 24 weeks looking at lung function, and also followed through 48 weeks in a placebo-controlled fashion, followed by Ivacaftor open label. And the next slide just summarizes the results of one of those trials, the larger trial in the patients ages 12 and above. And this study was called STRIVE, and it was published in 2011 in the New England Journal of Medicine. And what we see at the top left is looking at the improvement in lung function in Ivacaftor-treated patients with the G551D mutation. We're looking at the absolute improvement in FEV1 above baseline. The blue is the patients treated with drug, and the black line is basically the placebo group. And you can see that there is a rapid improvement in lung function of approximately 10%, which is maintained throughout the duration of the entire trial. If you go to the top right, it's looking at a Kaplan-Meier curve, essentially looking at the risk of developing a pulmonary exacerbation. And so the Ivacaftor group had a much reduced or much higher event-free or a lack of pulmonary exacerbations over the period of the study, over a 50% reduction compared to the placebo group. In the bottom left, we're looking at one of the patient-reported outcomes, the CFTR, which basically measures the respiratory domain, and basically measures respiratory symptoms in CF patients. Again, seeing a rapid improvement. Anything over 4 points is considered clinically relevant. And then finally, on the right side, bottom side, is looking at weight in kilogram change. And again, a rapid, steady improvement in weight seen in the CF patient. So clearly, this drug was having profound effects across a number of efficacy outcome measures, and again, which led to its approval in this population. Subsequently, this same drug has been studied in other mutations, in patients who have much more rare mutations, and these are non-G551D gating mutations. And this data was recently presented in the 2013 North American CF Conference a couple of months ago. And as we look at the population, very small sample size, less than 1% of CF patients have one of these mutations. There is somewhat less mutation homogeneity. In other words, there's, I think, 8 or 9 mutations that patients had to have to fall within this study. But again, these patients would not have had background CFTR function, and again, for that reason, it ended up being a relatively clean study. Because, though, of the small number of patients, they had to take a somewhat different study design, which is shown here. A total of 39 subjects over the age of 6 years were screened, and they basically went into a double crossover design where they were treated with 8 weeks of Ivacaftor versus placebo, followed by a washout, and then would roll over to the opposite treatment in a blinded fashion, and then finally go into an open label. And without getting into the data, it turned out looking very similar to this data I just showed you before. Lung function improvement was approximately 10.7% within 2 to 3 weeks of initiating treatment, looking very similar to the data that was found in the G551D population. And I'm just going to show you the next slide is just looking at an in vitro readout of all those different mutations. These are all the different mutations. This is from a model system in which they're looking at a kind of stable mutant CFTR expression across in a common cell line, essentially. And what they're looking at is chloride transport, which is a very well-established readout of CFTR function. The far left is basically the normal or wild-type CFTR function. The white is the activation by the sort of the standard fashion, which is cyclic AMP. And the black is the improvement on top of sort of background activity that is produced by Ivacaftor. And so that red bar represents essentially background wild-type CFTR function. That's the bar that we're trying to approach. And as we move across from left to right, we look at the F508 mutation. You can see that there's really very little effect because that mutation has so little available to cell membrane. G551D is shown next. It has a significant improvement. Interestingly enough, it's not the best, though. You know, as you look across the other mutation, there's a number of these other gating mutations which have at least as much or more activity as you move across. And so based on this type of preclinical work, coupled with the success of the original Ivacaftor study in G551D patients, they were able to develop a study that was very nimble and capable of showing their effects despite a relatively broad number of mutations represented. The next study, which we don't have data on yet, but I just wanted to show you, followed a similar general design as I showed you before. This is a study looking at Ivacaftor in CF patients who have the R117H mutation, and this is enrollment has recently been completed. We're all looking forward to the results of this trial. It's called the CONDUCT trial. And as I mentioned earlier, R117H is a very different mutation in the sense that, yes, it gets to the cell membrane, but part of its problem, or at least maybe a larger portion of its problem, is it's a problem with conduction. But it has been shown in preclinical model systems to be, its activity is improved by Ivacaftor. So as we look at sort of the study design considerations, a very small population, about 1% of CF patients, the mutation homogeneity, R117H by its nature has some variability. This is going to be covered in some of the other presentations, but specifically, while it has partial function, it also is influenced by how much of it's available at the cell membrane, how good its splicing efficiency is. And that can have a big influence on the phenotype. So it's not a very homogeneous group. It does have some level of background function, and because of all these reasons, there's much more likelihood of confounders. And this is the first time that they looked at this drug outside of a gating mutation population. So they've certainly tried to manage this by the inclusion and exclusion criteria. The total number of patients screened, I believe, is in the range of 80. I couldn't give you an exact number because the data hasn't been presented yet. But this is the design, as you can see, rather similar to what we saw before with the gating mutation population, with a crossover type of design, followed by an open label period. So we look forward to this because this would really be the first demonstration, if successful, that this drug can really be applied outside of the gating mutation population. Next, I want to talk a little bit about addressing patients who have 2 copies of F508. And this is being addressed currently by a combination drug approach in which patients are treated with a corrector, a drug that helps to fold or improve the trafficking of F508 to the cell membrane, plus a potentiator, and specifically using Ivacaftor as a second drug to maximize the activity of CFTR, the delta F that they get to the cell membrane. Two types of drugs are under evaluation. One's called VX809 or Lumacaftor, and the second is VX661. And it doesn't have another name at this point. And these studies they've completed phase 2, and the VX809 studies have actually progressed into phase 3, but VX661 has additional phase 2 work that's ongoing right now. So the sample size is relatively large in terms of CF, with about 60% of patients carrying 2 copies of F508. Mutation homogeneity, yes, these patients obviously have 2 mutations, so therefore that is the same, so it's less of an issue than some of these other prior studies. We would not anticipate that there is much of any background CFTR function in those, so for several reasons we think the confounder problems are less. The preclinical model systems have shown moderate treatment effects, as have the phase 2 studies, and I will show you some of those results in just a moment. Some of the challenges for this is it is a difficult mutation to fix. In addition to getting some of it to the cell membrane, we have to improve its activity once it gets there. So it really requires a 2-drug approach that, by its very nature, is going to be complicated. So the challenges that are really being addressed for bringing new drugs to the F508 patients is the challenges that come with 2-drug or co-therapy development. There's a disconnect between the biomarkers, and I have your sweat chloride, one of the biomarkers that was very helpful for the potentiator studies, have not been as helpful in patients with 2 copies of F508 for a variety of reasons. And they haven't been real predictive of patients and their lung function improvement. And finally, there have been some complex study designs necessary, and I'm just going to show you an example of that for the VX809 plus Ivacaftor studies that have progressed through phase 2 and are currently in phase 3. So these were results that were presented from the 2012 North American CF conference, and this is looking at VX809 plus alone and in combination with Ivacaftor in patients with 2 copies of F508 and also patients who had 1 copy of 508. And what we're looking at here on the left side are basically the different cohorts. Patients who had two copies of F508 for the first 28 days were treated with 1 of 3 doses of 809, either 200, 400, or 600 milligrams per day, or placebo. And then finally, there was the high dose group. There was a high dose cohort of patients with 1 copy of F508 and 1 other non-F508 mutation, but did have CF, and to see if this drug was effective in that population too. And I won't go into that data today, just because it's still under analysis, but it doesn't seem to have it does seem to have some effect, but not as strong as 2 copies of F508. So in these studies, the first month was spent on 1 drug, and then the second month, Ivacaftor was added at a common dose across all the studies, as shown here. And so, as you can see, it's a relatively complex design, having a sort of a 2 periods of treatment for each of the different cohorts within the study. And what I'm showing in the next slide is just the improvement in lung function, or the change in lung function from baseline during the first month of monotherapy, followed by the second month of co-therapy. And I'm just showing you the placebo versus the high dose. It just shows the data most clearly. The placebo group had a mild reduction in lung function, as shown in the dotted line over the first month, but really didn't meet statistical significance. But interestingly, the 809 alone, there was, if anything, a little dip in lung function that was seen in the first month. And again, we're all very curious about the reason for that, and that's ongoing research right now. When Ivacaftor was added for the second month, you can see that there is a steady improvement in lung function that is seen in the patients treated with VX809 plus Ivacaftor in blue, compared to patients who were treated with placebo during both periods, shown in the dotted line. So the treatment effect was a little over 6% in the FEV1, which is felt to be likely clinically relevant. This has led to the design of phase 3 studies, which are currently ongoing in patients with 2 copies of the F508 mutation. Last, I wanted to just summarize some of the work going on with suppressors. Again, these are drugs which are trying to suppress premature termination codons and restore function to mutations that have this biosynthetic defect. The one drug that is currently in phase, or has had a recent phase 3 study, is adalurin, and it's previously known as PTC-124. This approach is obviously very interesting for a number of genetic diseases because premature termination codons are by no means specific to CFTR. There are numerous other in fact, essentially all genetic diseases are characterized by at least a subgroup of mutations which fall into this class. So certainly what we can find in CF is going to likely be relevant to other diseases. The population is relatively small, but certainly bigger than some of the prior ones. Somewhere in the 7 to 10% of patients carry at least one premature termination codon. Mutation homogeneity, in other words, different mutations may have different behavior depending on where the premature termination codon is in CFTR and what's the surrounding context. So that does complicate study designs. In general, we would not anticipate background function in these mutations, but really because of the variability in the mutations, there's some concerns that there may be some confounding in these studies. The preclinical model studies showed moderate treatment effects, and the phase 2 studies, there were essentially 3 that were performed, 2 of which showed evidence of clinical or of drug activity, while 1 did not. But based on these results, a study design that was really straightforward was developed and is shown here, where 208 subjects were enrolled across 41 sites looking at a number of endpoints. And half of them were treated with adalurin for 48 weeks, and half of them were treated with placebo, and essentially 1 dose was used, and followed by an open-label period. And what was found in these phase 3 results, that overall the study failed to reach the primary endpoint, looking at the 48-week FEV1, which is a standard lung function outcome measure, and also looking at pulmonary exacerbations and a variety of other secondary outcome measures, such as patient-reported outcomes, CFTR biomarkers like sweat chloride, nasal potential difference, and cough. Interestingly, though, there was a subgroup analysis that patients who are not treated with inhaled antibiotics, when you look at that patient population, there actually seemed to be a stabilization in lung function and a reduction in the rate of pulmonary exacerbations. And so one of the working hypotheses from the study is that there's a confounding interaction between inhaled aminoglycosides and study drugs. And an example of the data is shown here. On the left side, we are looking at the FEV1 difference between the active and the placebo groups at week 48. And as we move from left to right, we're looking at FEV1 difference at 48 weeks, which is very small, about 3%, not statistically significant. If we looked at all the FEV1 measurements across the entire study, essentially every month, you would see a statistically significant difference between the 2 groups. And on the far right, on the kind of that left figure, this is looking at the FEV1 difference in patients who were not treated with any inhaled antibiotics. And so there's around 52 to 53 per group. And you can see that there was a treatment difference above 6% that was statistically significant. On the right side is looking at the reduction in acute pulmonary exacerbations. That's what APX means. And we're just looking at a percent reduction of all patients. On the left side did not meet statistically significant differences compared with placebo. But on the right side, if you excluded the patients on inhaled antibiotics, we did see a statistically significant difference. So this has led to the design of a subsequent phase 3 study that will be excluding patients who need a certain class of inhaled antibiotics. And so we're looking forward to getting started on that in the next year and hopefully get clarity about whether this is a new therapy that we'll be able to offer to patients. So just to kind of summarize where we stand right now, what studies will bring modulator therapy to different CF genotypes? So on the left here, if you kind of start with all CF patients and start to try to break them down by sort of their common or the mutations that they have. The very bottom is the gating mutation, and again, just in number. Those patients in general we think are going to be candidates for potentiators alone. Patients who have 2 copies of F508 are likely to be candidates for a corrector and likely be combined with a potentiator such as Ivacaftor, which is now FDA approved at least in one population. And we think that will probably apply to patients who have 1 copy of F508, but they'll likely need to be more dose ranging to determine what's the most efficacious treatment regimen for them. And then we start to get into those rare populations. Obviously, we talked a little bit about the premature termination group. They are going to need some different study designs than what was done prior, and need to think about potential confounding effects. And going into populations with missense, splice, conduction type of mutations may require some very novel designs because of the small number of patients which are found in each of those study groups. And finally, just mentioning that Ivacaftor strikes me as a drug that's very, very possible will play a role in their therapy too, as it seems to have the ability to improve the activity of CFTR that's available at the cell membrane, a number of CFTRs at the cell membrane. So bringing CFTR modulators to rare and less characterized mutations becomes a bit more of a challenge. First, there's a lack of good surrogate endpoints that can help us know that these drugs are effective. And therefore, because of the small numbers, we would likely have to have very, very, very long studies, and that becomes rather unfeasible, as you might guess. And second, cost and third-party payer coverage will really require firm efficacy data because these are rather expensive therapies that are under development. So having firm data to justify their use in sort of smaller and smaller populations will be really important. So there are a number of approaches which are being piloted, looking at individualized studies in patients with residual CFTR functions. One is an approach that's undergoing using an N of 1 approach, in which patients are treated with off and on drug or placebo in a very standardized fashion that is blinded to both the investigator and also to the patients, but they're all sort of enrolled based on a very broad sort of spectrum of background phenotype, and then serve as their own control through the studies. And again, the principles of this are under development, but we look forward to seeing those results soon. And also, it reminds us too of the importance of having a blinded study examination, because what we learned in one of the earlier phase 2 studies of VX770 is that one of the placebo groups had a very dramatic improvement in lung function that was somewhat unexpected, and that just reminding us the importance of having a very clear design with challenge and re-challenge to ensure the treatment effects are real. And finally, a CFTR database that has been recently updated and sort of somewhat broadened, but also standardized, is the CFTR2 database, which is a topic of another speaker in these groups of talks. How important that will be for us to help select patients who might be candidates for some of these novel therapies and designs. Last, I wanted to just mention some of the complexities of bringing CFTR modulators to young children with CF. There are a number of parameters that are clearly need to be thought about and clearly are necessary, but as we move our way down, looking at safety, obviously that's a very critical aspect to consider, but it becomes really difficult in orphan diseases. Getting enough information about safety in somewhat older populations to be able to, and whether that's really going to translate to safety information in younger populations. Pharmacokinetics and dosing becomes more challenging because of changing metabolic systems, and so being able to come up with appropriate dosing can take work, and the absorption of these may sort of vary from patient to patient depending on pancreatic function and so forth. The formulation itself, can it be put into a form that can be either put in a liquid or dry powder form, or something else that can be as appropriate for using in a very young population? As you might guess, that can be very complex. And finally, efficacy. I just put a question mark here because we're still wrestling with what are the best efficacy measures in CF infants and toddlers. Thankfully, most of these patients are quite healthy, and being able to demonstrate that this is providing a benefit can be a challenge. And as we think through this, there's kind of a balance between maximizing maximize prevention of disease versus minimize the risk of a lifelong therapy. And there are a number of considerations, ethical and financial, that sort of feed into this. And this kind of application, this sort of thought sort of applies to other populations, patients who have very high lung function, patients who have very low lung function, patients who have sort of unusual infections and have been excluded from studies because of concomitant medications. So that, again, these are, I don't have answers for these today, but these are things that we're wrestling with in the field. So finally, I just wanted to summarize, in CF, we think this is an extremely exciting time. Therapies that are targeting the mutant CFTR that causes disease are approved. One is approved, Ivacaftor, and phase 3 studies of Ivacaftor, Ivacaftor, Adalorin are either well underway or completed, and so we're really starting to realize the work of the last decade to bring this to clinical trials and hopefully to patients soon. Study designs depend on a number of interlinked factors. I won't repeat them here. You can read them for yourself, but the point is they really have to be thought carefully as we bring these new drugs into new populations. Developing co-therapy is really difficult, as you might guess. It requires sort of a number of different considerations, just even beyond pharmacokinetics and study design. And finally, novel designs need to be considered when we're bringing these drugs into new populations, such as those with rare mutations, young, or sort of extremes of disease. So I think that's it, if I'm not mistaken. Yes. So I want to thank the organizers for the opportunity to present today, and I hope this has been helpful to update you on some of what I think is really exciting work that's going on in CF that will, we think, be transformative over the coming years.
All right. Thank you very much, Dr. Clancy. That was very useful. Features of a disease and how it's treated are often things that people consider when contemplating carrier types of studies being done. So we appreciate all the